This topic is ulcerative colitis. Ulcerative colitis is a chronic autoimmune condition that affects the inner lining of the colon, hence the term colitis. Clients with ulcerative colitis will have recurrent periods of inflammation that affect the colon, and this leads to ulceration of the GI mucosa as well as loss of colon function. Let's take a look at the image on the right to better understand how ulcerative colitis develops. First, inflammation will typically start with proctitis, which is inflammation of the rectum. This inflammation within the rectum will begin to progress upwards and start involving other portions of the colon. If inflammation is severe or left untreated, the entire colon can become inflamed. With ulcerative colitis, the inflammation is contained to the inner lining of the GI mucosa and doesn't progress into the other layers of the intestine. Let's compare ulcerative colitis with Crohn's disease. Both of these disease processes fall under the category of inflammatory bowel disease. The top middle image shows the inflammatory process involved in Crohn's disease. Essentially, inflammation is going to start somewhere in the small intestine and will progress its way down. This inflammation is also not continuous and can skip certain areas of the bowel itself, leaving what are known as skip lesions. So we have areas of inflamed tissue that are separated by areas of healthy tissue. In contrast, ulcerative colitis starts in the distal colon or the rectum and progresses its way upward through the sigmoid colon. Now let's look at the middle image at the bottom of the screen. With Crohn's disease, we have inflammation of the entirety of the intestinal wall. The significant amount of swelling can cause a decreased lumen size, which can lead to the development of strictures and obstruction. In contrast, if we look at the image at the bottom right, which shows us what happens with ulcerative colitis, again, we only have that inflammation of the inner lining of the intestine, which still allows for a decent amount of interluminal space and allows passage of contents. One of the most common non-modifiable risk factors is a family history of ulcerative colitis. Modifiable risk factors are usually associated with things that cause direct or indirect stress to the gastrointestinal tract, such as the use of non-steroidal anti-inflammatory drugs. Any type of stress that the client experiences can enhance that autoimmune response. And if the client uses irritants like tobacco products. Because the colon is primarily affected with ulcerative colitis, symptoms will be associated with that inflammation of the colon. Again, the colon is very important when it comes to water absorption within the gastrointestinal tract. Therefore, the client may have frequent and bloody diarrhea. Sometimes this diarrhea may contain mucus or pus. While certain individuals have less frequent episodes of diarrhea, severe inflammation can cause clients to have up to 10 to 20 episodes of diarrhea a day. When a client is having this much diarrhea, fecal urgency and incontinence can result. With inflammation comes an increase in peristalsis, which can lead to abdominal cramping and pain. With the presence of inflammation, we may expect a fever, and because this autoimmune process is chronic and occurring over a long period of time, the client can have weight loss and fatigue due to an increased metabolism needed to maintain that autoimmune process. Extraintestinal manifestations may occur due to that autoimmune process, and this can involve changes to the skin, to the eyes, and the client may develop some joint pain. And symptoms can last for several weeks to months at a time, which can be extremely debilitating. There are a number of diagnostic tools that can be used to aid in the diagnosis of ulcerative colitis. For one, we can look at a complete blood count, and if we notice any anemia, especially a low hemoglobin count, this can be due to the presence of hemorrhage within the GI tract. And anemia is common with a multitude of diseases of chronic inflammation. An elevated erythrocyte sedimentation rate, as well as an elevated CRP or C-reactive protein, is also indicative of the inflammatory process. Ulcerative colitis leads to serum electrolyte imbalance, especially when it comes to potassium. And with the use of a colonoscopy or sigmoidoscopy, the healthcare provider can visualize the area of inflammation, as well as collect a tissue sample through biopsy to analyze in the lab. Complications include malnutrition and fluid and electrolyte imbalances. Again, the colon is very important when it comes to absorbing water, nutrients, and electrolytes from our gastrointestinal tract. With irritation of the colon tissue, this can lead to hemorrhage, and if they hemorrhage, they become anemic. Now, with fluid loss due to hemorrhage, as well as that decrease in water absorption from the gastrointestinal tract, these clients can be at risk for hypovolemia, which can lead to hypovolemic shock. Toxic megacolon is another complication that can occur, leading to perforation of the bowel, and this is something that we'll talk about on the last slide of this presentation. Any type of chronic recurrent inflammation can increase the risk for cancer, and with a large amount of diarrhea passing through the colon, this can lead to a loss of good and bad bacteria within the gut, which can lead to the development of C. diff infection. During an acute exacerbation of ulcerative colitis, one of the first things that we should do is implement bowel rest. This will help reduce intraluminal irritation and inflammation. If the client is able to tolerate a diet without symptom exacerbation, then we should go ahead and encourage them to eat. However, if a client requires prolonged bowel rest, they may need parenteral nutrition. We want to correct fluid and electrolyte imbalances. So we're most likely going to be IV fluid resuscitation, as well as replacing any electrolytes that are lost. Intestinal absorption of potassium is decreased with colitis, therefore, we should anticipate administration of potassium. We should monitor bowel sounds and monitor for abdominal distension. We should also anticipate the collection of a stool sample. This is to help the healthcare provider rule out the presence of infection which may be causing these symptoms in the first place. There are certain medications that we give when it comes to inflammation, like 5-aminosalicylates, such as mesalamine and sulfasalazine. These medications are given primarily for inflammatory bowel disease and work especially well with ulcerative colitis to help reduce inflammation. Corticosteroids are also given for inflammation, however, they're used for a shorter period of time. We should monitor for blood loss. Again, the client can have a little bit of GI bleeding when it comes to colitis. And in severe cases, when medications or other interventions fail, we may need to prepare the client for surgery, such as a colectomy with or without ostomy creation. Client education focuses on preventing an acute exacerbation. So we want to teach the client to avoid certain triggers like caffeine, alcohol, and fatty food consumption. We want to encourage the client to stop smoking and using tobacco products. Medications such as sulfasalazine are continued even after symptoms are resolved, as this will help prevent a recurrence. And in severe cases, the client may be started on biologic therapy. Now, it's important to note that biologic therapy can reduce the immune response throughout the entire body. So clients starting biologic therapy should be screened for TB as well as hepatitis. And during therapy, clients should avoid live virus immunization. During periods of exacerbation, the client should consume a high protein and low fiber diet. They should supplement their diet with vitamins and minerals as needed. Frequent small meals can help reduce inflammation within the bowel. And the client should be consuming at least 2 to 3 liters of fluid a day to help prevent dehydration. Medicated creams, witch hazel, and sitz baths can be used for perianal irritation due to frequent diarrhea. Let's revisit toxic megacolon. Toxic megacolon is a life-threatening complication of ulcerative colitis that occurs from GI smooth muscle paralysis. If the inflammation of the colon is severe enough, the smooth muscle becomes paralyzed, which leads to cessation of diarrhea, as well as accumulation of gas and stool within the colon. As these waste products accumulate, the client is more at risk for developing systemic toxicity. So it's important to watch for things like fever and hypotension, as well as tachycardia. And lastly, the colon can dilate to a size that's very large and creates a lot of pressure within the lumen, which increases the risk for bowel perforation. Again, this is a medical emergency. The client will need bowel decompression and IV corticosteroids to reduce inflammation and promote return of bowel function.